Hey everyone, and welcome to Dr. Nova Pods, where we turn complex clinical cases into memorable learning moments. Today's case is about Mr. Rajesh Patel, a 45-year-old shopkeeper who walked into the clinic with a rather unusual concern. He needed bigger shoes and couldn't wear his wedding ring anymore. Over the last 3 years, he noticed a change in his facial features: a broad nose, enlarged jaw, and thickened lips. Alongside this, he had frontal headaches, joint pains, and episodes of excessive sweating. Ugh. And he snored so loudly, his family sent him to the guest room. On examination, Rajesh had coarse facial features, macroglossia, and bitemporal visual field defects, suggesting pressure on the optic chiasm. His serum IGF-1 was elevated, and GH levels failed to suppress after a glucose load. An MRI confirmed our suspicion, a pituitary macroadenoma. Final diagnosis: acromegaly, caused by a growth hormone-secreting pituitary tumor. Quick background check on the diagnosis. GH is normally secreted by the anterior pituitary and stimulates the liver to produce IGF-1, which promotes growth in bones, cartilage, and soft tissues. In acromegaly, growth hormone is excessively secreted, most often by a benign tumor called a somatotroph adenoma. This leads to progressive tissue overgrowth and metabolic disturbances. We have a mnemonic: big hands for acromegaly features. B, broad facial features. I, increased GH-IGF-1. G, glucose intolerance. H, hypertension, headache. A, arthritis. N, neoplasm, pituitary adenoma. D, deep voice. S, sweating/sleep apnea. The first-line treatment is transsphenoidal surgical resection. If the tumor isn't fully resectable or recurs, medical therapy with octreotide or pegvisomant is the next step. Regular monitoring of IGF-1, MRI, and metabolic profile follow. And that wraps up today's case, a classic presentation of acromegaly, and a reminder of how subtle changes like larger shoes can lead to big diagnoses.